The first session will focus on trauma training, preparedness and ECMO, the topics that continues to shape the future of emergency and trauma systems globally. This important session will be chaired by Dr. Scott DMS, and sir, we are truly honored to have you here today with us. And our speakers would be Professor Sivaganesh from Sri Lanka, Dr. D. Westerbrand from United States, Dr. Hendro Wartatmo from Indonesia, Dr. Akaraborworn from Thailand, and Dr. Chotirosniramit from Thailand. We look forward to a stimulating and insightful discussion from this distinguished panel. Please note that today's session will be interrupted briefly at 9 in the morning for the official inauguration ceremony of the conference, after which the scientific program will resume. So without further delay, let's begin the first session of 2025 National Trauma Conference. Sir, the session is over to you.
On behalf of our organizing committee for the Region 16 meeting, I'd like to also share my welcome to the beautiful Gullface Hotel. We're very lucky to be in such a building. I had a tour through it last night of the various areas that we're using, and it really is spectacular. Built in 1864, and the various people from around the world, luminaries, politicians, popes that have stayed here. The list is very long and remarkable. So for those of you that are in the breakout rooms this afternoon, you'll see some of that history, and it really is quite extraordinary. I would like to thank the organizing committee for their very hard work on this program. We've had to rejig a few things, so there's been a few corrections to the program. The program that you would have been sent on WhatsApp last night will be the most up to date. And there have been, as I said, a few changes, so I will take you through those as we go through the program. I'd also like to welcome my co-chair for this session, Professor Amit Gupta from India. And as you heard, originally our session was to go through to morning tea, followed by the inauguration session afterwards. That was then updated yesterday to accommodate the minister's schedule. I've been recently advised that the minister's schedule has changed again. So we will go through, I think, with the whole morning session uninterrupted, but if that changes, I will let you know. Again, welcome to the Region 16 meeting, and thank you to all of our presenters who have offered to present things and agreed to present things. And also for our coordinators who are in attendance. It's very important that this regional meeting has representation from each country, from their national coordinators, their national educators, and I know we have a good number of them here today, which I'm very pleased with. So without further ado, we'll get on with our morning schedule, and I'll introduce our first speaker. Our first speaker is Dr. Sivaganesh. I've known Siva for a number of years, since the time that we promulgated ATLS here in Sri Lanka. So I'm delighted that he's here on the program. He's a professor of surgery and professor of trauma, and we're delighted that he's agreed to speak on ATLS and training for trauma in Sri Lanka. Welcome.
Thank you, Scott, for that introduction. My task here is to give you all an introduction to the system of trauma training in this country. I wear two caps in that I am a university academic as well as the chair of the Board of Studies, so I'm involved in both undergraduate and postgraduate medical education. And this is primarily to give those of you who are visiting us from around the world some context to the health system and the health education system in this country, because context is everything when going forward. So, so obviously, like all parts of the world, trauma is one of the major health problems in this country, and effective trauma care results from good training. To give you a brief on the landscape of both the health system and medical education in the country, they are strongly interlinked. We have universal access to healthcare at the point of care. And the two pillars of health in this country are the state medical education system, which is free for all, and the state health system, which is also free at point of care. So these have been the pillars of the health system in this country, and they are strongly linked as well. So that's us. To just put things in perspective, where does Sri Lanka stand in terms of certain key indices? And you can see our per capita expenditure on health is about 150 to 60 US dollars, and you can look at the comparisons globally. And again, this gives you context to our health system. In terms of our doctor patient population, we've exceeded the WHO requirement of 1.2. Now, if you look at medical education, we've got two, both undergraduate and postgraduate. As I told you, this is run by the state. We've got a University Grants Commission, under which you've got 12 state medical schools, and there's a medical school that's under the Ministry of Defense, where the undergraduate medical training program is 5 years. And then we have the centralized postgraduate medical institute, which runs postgraduate medical education in this country. So these are the two pillars of medical education, both undergraduate and postgraduate, and they are centralized. If you take undergraduate trauma care training, I'll speak briefly on that. Like I'm sure in all systems around the world, they are covered in very clinical subjects, principally in surgery and emergency medicine, and they've got a combination of teaching learning methods, as I've said, with the focus being mainly on assessment, resuscitation, and initial management skills. If you take our medical school, and I represent the Faculty of Medicine in the University of Colombo, undergraduate medical students go through exposure to trauma in appointments of surgery, orthopedics, neurosurgery, and so on. We also have, from 2021, a trauma module which is based on the learning management system, the LMS. It is an interactive online learning system based on the ATLS program. In fact, we've got the required permissions from the ATLS to use their material on our online system. And this has proven to be quite popular, and it's now accessed by two of the newer medical faculties as well, who also have access to this system. So this is to give you a snapshot of our online program. It's interactive, it has formative assessments, and students have access to this throughout their years in medical school. And that's one of the lessons that are there. So it's almost exclusively based on the ATLS model. As important is assessment of trauma care, and we run formative and summative assessments in the form of OSCEs, where we would have skill stations where undergrads would have to be able to demonstrate basic skills. And in our MBBS, which is the final examination for undergraduates, both in the theoretical components of multiple choice and SCQs, you would have a fairly significant representation of trauma. This is one of the typical SCQ, for instance. You would see of the last paper where they would be given a scenario and have to work their way through answering question on trauma. So we put a lot of emphasis into trauma. We want them to have a good base in their undergraduate days so that they can pick up as they move further. Postgraduate medical education, in a nutshell, those who've done at least 2 years of post-MBBS medicine are eligible to join the program, and if you take surgery, there is a pre-MD, or what we call co-surgical training, which is about 3 years. They do an examination which then helps them to transit to specialist surgical training, which is about 4 years. So we're looking at about 7 to 8 years of overall postgraduate training, after which they are board certified, and this comes under the purview of the Board of Study in Surgery, and that's of course part of the National Postgraduate Institute of Medicine. So that's the structure of training. During this, again, the exposure to trauma is quite significant. They get it during their clinical rotations. They've got clinical rotations in general surgery, in teaching hospitals, and in peripheral or district hospitals. They've got rotations in the accident and emergency departments of certain hospitals, neurosurgery, vascular surgery, and so on and so forth. So all these carry a fairly significant exposure to trauma. There are mandatory courses that they need to complete to be able to get their certification, ATLS being one of them, and then we've also got the National Trauma Management course, NTMC, which preceded ATLS, it's been there. Then we've got definitive management of major trauma for definitive trauma care. That's still not mandatory, but with the revisions that are coming up in our surgical curriculum, that would probably also be there. Not just courses and exposure, but we also encourage research, and we have a significant number of trade papers being, abstracts being submitted to national sessions, for instance the one today, and also at the academic sessions of the College of Surgeons of Sri Lanka. So those are some of the aspects of training. Again, our intermediate or the MD examination from core to higher surgical training has a significant amount of trauma blueprinted into it. If you took we've got 100 SBA multiple choice, we have at least, we ensure about 10 to 15% of trauma. 1 out of 4 structured questions are trauma. We've got OSCEs which have cold trauma, and trauma is also dealt with in our structured vivas, both in operative and principles of surgery. So it's quite extensively blueprinted even into the assessment system. Of course, nothing is done in isolation, like we're all here today. We collaborate a lot. The Postgraduate Institute of Medicine and the Board of Study, our key collaborators are the College of Surgeons of Sri Lanka. ATLS from 2016-17 has helped tremendously towards taking trauma care forward. And the ATLS teams in this country have also taken trauma to the peripheries, and there are these outreach programs that are conducted in hospitals out of the main cities as well, to improve trauma care in first contact doctors, not just trainees. Of course, if you would have figured out from our first slide, We have challenges. Sri Lanka is sort of coming out of a fairly difficult period. Resources. In conclusion, trauma training is obviously a very essential part of medical education, and we've incorporated it at all levels of training in Sri Lanka. Obviously, we would like to keep improving as we go along, and collaboration and innovation are, I think, the key to taking this forward. Thank you very much.
Thanks. If you have questions, please do write them down. We will have a panel at the end where we can discuss many of the things that come up throughout this program. So please write down your questions and we will come back to them for the panel at the end. I'd like to introduce our next speaker now. The one that was on your original program, Professor Danny Westerband, was unfortunately unable to attend due to illness. So I'm grateful. Would you say indebted, Narain? Indebted, would that be the right word? That Professor Narain Chotirosniramit from Chiangmai University in Thailand has agreed to a second talk in this session. So I'm grateful to you for that. Thank you, Narain. Professor Narain, as I said, is a professor of surgery and a professor of trauma from Chiangmai University, and he's also recently a new dean of the medical school there. So I hardly hear from him anymore because he's that busy with all of the requirements of that new position. But we're delighted that you're here. We're delighted that your team is here as well, and grateful for your presentation. And he'll first be presenting on helicopter emergency and retrieval in Thailand. Welcome, Narain.
Thank you very much, Scott, for your kind presentation, and good morning, all participants for this conference this morning. I have nothing to disclose. I'm going to talk about the helicopter emergency medicine services in Thailand, and I'm going to give you some idea of how to manage, how to build up the team, and finally, it's kind of like this storytelling. It's just like one of the examples that we can start our job for this. This is Chiangmai, and that white building that you see, it's my hospital. We are in the middle center of the Chiangmai city. We have a capacity of about 1,400 beds hospital and teaching hospital as well, belong to Faculty of Medicine, Chiangmai University. And the problem of emergency cases at time, actually in our northern regions, we work up there. We have 13 regions in Thailand, and they have to work in the group. 70 provinces have divided into 13 provinces. And in that circle, red circle, it's the region 1 that we work for. We do have a lot of fast track for the trauma case, for the emergency, stroke case, acute myocardial infarction in our hospital, in our province. But the problem is during we stay in Chiang Mai, all over the part of Chiang Mai, Chiang Rai, Nan, and many provinces in the north, they have so many mountains and difficult to reach the healthcare. They have a local facility like a hospital, local hospital, and but referral from the hospital to the other hospital is very difficult. One time I went to the village for the visit. There's one car crash up to the hill in the mountain, and they just have to carry the people down like this. I'm the one who visit that point and also go up to the hill to take care of them, but I have no instruments. We have to walk by our foot from the mountain down to the local facilities and take care of this kind of ladies. She got injury like abdominal trauma and back pain, but you know the problem of carrying is very important. So at that time we have to carry this kind of patients down to the river. along the river in the border between Thailand and Myanmar, and carry about 45 minutes by boat, and then come up to the land and go to the bigger hospital. This is the difficulties of people in the northern part of Thailand, in local area, and very difficult to take care. Even I was there, I cannot help them because I have no facilities. This is reason why very beautiful area like Chiangmai, like Chiang Rai, it's difficult to carry the patient for referral. So sometimes we have to go by car. We took at least 3 or 4 hours from that province to Faculty of Medicine, Chiangmai University by car, very long distance. So this is reason why we have created the team we call Northern Sky Doctor in the northern part of Thailand. Because we have to carry people across the mountains directly to the center of the city. When we talk about the helicopter transfer, you think about the Dr. Haley that you can see in the Japanese drama. You can see the Dr. Haley we call Code Blue series. But in Thailand, we do not have any ambulance like this. We have just the military ambulance, like military helicopter. So we have to borrow the helicopter and the pilot from the military to do this job. And on the beginning, we do have some problem because, when you want to fly, you need to have the helicopter. So if you don't have, you cannot fly. You have to have the doctor, nurses, paramedic who know about how to take care of the patient on the air. And you have to find out the funding support. So in Thailand, we start at the right lower corner, it's me. I used to have a very long hair during when I was young, 20 years ago. We sit down and talk to the military people that, can I borrow your helicopter? For carrying some people, some patients for the mountain rural area, go to the center of the city. We have agreement and we signed an MOU together to have agreement that when we activate, if there is no task of the army, we can borrow the helicopter and also the pilot, because I have no pilot actually. So the funding, we negotiate to the National Institute of Emergency Medicine to have a guideline for paying for the cost of flying for the owner of the helicopter. And also we train people in the northern part of Thailand. We have the training and drill together with the military and the Air Force. And after we train, we fly the first case in the 2010, the first lady who had 74-year-old with acute stroke from the Mae Hong Son province, fly to Chiangmai. We can save time more than 3 hours for taking care of that patient. And we continue to build the team capability by we have a big conference and training for people in the northern part of Thailand we call ACAAT in 2014 and make it advanced by some instructor or teaching coaching from the other country. This is some of the picture that we have trained, and also I'm the one of the people who get trained at that time and also get the certification at that time, and also some of our friends from Italy, some of our friends from Japan, and some of our friends from Korea come to help us for teaching and training people. And after we do it, continue us doing, we focus on the qualities by we have the guideline. We sit down and write the guideline for using the helicopter, what we can do on the plane, what we can do on the helicopter, and where is the spot for landing of the helicopter, and put in the guideline, in the manual, and we use it. And after that, we have the ceremony for getting honor for people who work for this, because they did this job for free without any salary. They just get the salary from the hospital. But during the flight, they are emergency nurse, we are the doctor, the surgeon, emergency medicine, paramedic. They work for free, like volunteer. So we give them the honor. And this is some photo of the flying that landing in my football field in the hospital area. You can see the white building, that one, the backside, it's my hospital. And we have a big soccer field in the area of the hospital, so they can land at that site. And this is some photo of the people who's flying inside. Actually, it's a video clip, but it doesn't work because of the file transfer has some problem. And we expand in all over the place that where is the helicopter that we can borrow in all over the northern part of Thailand. And we expand a lot and have agreement, a lot of military helicopter and Air Force. And then we get the order from the country that this process is one of the best innovation process that we have for the government worker. And also we get the certified standard by NEEM. They write down the standard and they verify our team in non-profit Thailand. And after that, we expand our work to all over the country. I mean, nowadays, all over the country, not just region 1, along the south side, east side, and central in Bangkok, they also have the same process. And we do have the national guideline for having the helicopter transportations for people, but we still have a gap. At that time, we're starting to do what we call the secondary mission. Secondary mission meaning is referral from hospital to hospital. But now we move since 2017, we moved to primary mission. I mean, we can land on the mountains and pick up people from the incident area and fly back to Chiangmai. This is one of the people who have the car crash, fall down from the hill and have the massive fracture on the right arm. So the helicopter land up there and just bring people back to Chiangmai University because they have the vascular injury and we repair it. This is the instance that we do. In the last few years, we got a lot of cases. Just in the northern part of Thailand, we have about more than 250 cases per year now. So average, we fly nearly every day for pick up the people. And this is the aircraft that we use in 10, 15 years. We use a lot of kind of aircraft, such as the Royal Thai Army, Royal Thai Navy, Royal Thai Air Force, police. So everyone is not real ambulance. This is different kind of ambulance that we use. And video clip is not working, so it doesn't matter. And now, the future, we're going to move our future higher qualities by moving to the TEMSA quality for the ambulance in Chiang Mai, in Thailand. So let me give you some example of disaster that happened in Thailand that we use helicopter for relieve the disaster. During 2011, we have a big event of flooding in central of Thailand, I mean in Bangkok. You can see the blue color is the area that has the effect of the flood, massive flood at that time. So this is a picture in Bangkok. You can see it in the news. Everywhere in Bangkok, I mean, majority, 70% of Bangkok get the flood, the same as you can see this one. And also the house, the two-story house, also just the roof that sparing people can stay in the roof, and they can use a boat in Bangkok for traveling. And also this is the bus, the public bus also got the flooding. And also you have some elephants from Ayutthaya come to carry people in Bangkok as well at that time. And also the National Institute of Emergency Medicine also deploy people and the truck to help for people for transportation. And some military also come to help by using the military vehicle, and also so many company of the making the car also the airport. I think this is the Don Mueang Airport. I think Don Mueang Airport also get flood. Don Mueang, the meaning of Don Mueang is the highland. Meaning of Don Mueang is highland. But Don Mueang also get flooded at that time. And the hospital also get some problem at that time. Many hospitals along the Chao Phraya River got flooded. And so many people, so many patients get a problem. On the left-hand side, I think it's the left-hand side, it's one of the centers that we have the command center. On the right-hand side, it's the International Suvarnabhumi Airport, the second airport, biggest one. We also have two sides of the Eastern Command System at that time. And here is the people, the assembly of people, healthcare, to help and transport also by plane and sometimes by helicopter to relieve the patient. This is one of the pictures that we relieve the patient from Bangkok to the north, to my place in Chiang Mai, because we have to evacuate the hospital at that time. And also short evacuation from the flooding site to the airport, we use a helicopter. So many people get help at that time. It's about 108 cases for helicopter and about more than 100 by C-130 and some CASA plane. And also by boat, so by ground. This is the event one. Even though you know about this picture, this is in Chiang Rai. We cannot call it disaster. It's just a massive news in this in the international. This is the mountain we call Kunam Nang Non in Chiangmai. You remember these 13 people we call 13 wild boars at that time. It's a big event. Because these boys have, after they practice the football, the soccer, they go to the cave for like relax, go inside the cave. At that time, they have heavy rain for 3 days. And they just go to the wrong place, wrong place, wrong time. So they get stuck in the cave at that time. This is the scenery of the cave that is very difficult to get into and get flooded. They're just stuck inside. And when people know, the local authority come and just call so many rescue team for the local come to help, but they found that no way to help. And also some military in the local area come and trying to take it out. And also the provincial governor is the incident commander at that time, Dr. Narongsak Osatanokon. And this is some photo that they try to help. Even they try to suck it out by using a very big tunnel to suck the water from the cave, but it's not possible. People sacrifice their landfill for put the water inside, but still so many water. And some helicopter giving the supply from the ground to the mountain area for helping. And also one of the most famous monk in the northern part also come to pray for helping. And so many people in front of the cave, so many medias come. You can see all over the world watching these 13 wild boar rescued. And our Prime Minister also come to be the Eastern Command at the time. And Navy SEAL from the south come to help. And this is the Navy SEAL who come and try. The best diver in Thailand go to join this one. And also international diver come. We lost one Navy SEAL at that time because they dived and died in the cave because it's very difficult. And the news go all over the world by the media. And also Elon Musk also come. They want to bring the capsules and put in the cave, but it's not successful because the capsule is too big and cannot flexible. But anyway, he leave one capsule for us to use in the future. And also President Trump also mentioned about this. At that time, he's the president. He also mentioned about, we are watching you doing some great job, something. And finally, the helicopter also brings some stuff on the mountain, also standing by for bringing the kids, if we can help them, bringing kids from the mountain to the hospital, Charters Way. At that time, we have about 6 or 7 helicopters standing by. It's not a disaster, but it's massive news. And finally, we got the best international diver who come, cave diver, and come and trying to see the kids, put the mask on and drive outside. 13 people, so get help. So finally, there's some events to helping. This is the northern part of Thailand also get flood. And here in Chiang Rai also get flood, a big flood at that time. About last year, Chiang Mai also get flood at that time. So we need the Nan also have flood. In the northern part, even if we have a mountain, we still have some problem during the heavy rain. And we use the helicopter for help evacuate people and also send some stuff to the house that stay on the roof, something like that. Finally, in summary, in Thailand, we have no air ambulance officially for public health. We use the military helicopter. So we train personnel at that time, doctor, nurses, and paramedic. So we got a budget from National Institute of Emergency Medicine. And the major incident that we use the helicopter is a flood. We need the patient's evacuation and send some stuff for the people. And finally, if we deploy, we need to have the incident command system. Thank you very much.
Narayan, it's always a pleasure listening to you, your practical experiences. And Dr. Narayan also has another feather to his cap that he's a pillar behind the Asian collaboration for trauma. And he was the one initially who started the whole Asian collaboration for trauma and remained the chairperson of the ACT. Thank you so much once again, Dr. Narayan. It's my pleasure to introduce the next speaker, Dr. Hendro Wartatmo. Dr. Hendro Wartatmo is a surgeon from Indonesia. He has got extensive experience in disaster medicine. He's also a member of the World Association of Disaster and Emergency Medicine, the WADEM, and he lectures in the Gajah Mada University in disaster medicine in Indonesia. Thank you so much, sir.
My slide. Good morning, all of the audience. Good morning, Scott. Yeah. Where should I point it? Oh, yeah. Yeah. I'm Dr. Hendro Wartatmo. I'm a surgeon and practicing surgeon. And in my country, I also the ATLS instructor from the first generation. I attended the course in 1995. Yeah, I'm so old enough. And now I'm the delegate of ATLS provider in Indonesia. It is ATLS of Committee Trauma of Indonesian Surgeon Association. Yeah, and here I would like to talk about the disaster because my country, people said that my country is disaster supermarket. Many of disaster happen in my country every day, every time, and all type of disaster. That's why I have a lot of experience in disaster response. Start from 1980, when I was a young doctor in a remote area health center. I should distribute the logistic because there is famine, and I distribute the logistic in some area is by horse, not the vehicles, because the access is not possible for vehicles. Yeah. And the red one is the disaster response when I lead the emergency medical team. Yeah. And the last one is in Garut, in one of province in my country, in 2022. I still there. Yeah. Yeah. So that's why my talk in this evening is about how should ATLS alumni do when they want to involve or to take a part in disaster response. Yeah. And I would like to start the presentation with the slide. Yeah, this is Dr. Steiner, what Dr. Steiner states after his accident with his family. And from this statement, I can get the message that at least two things, two most important things, yeah, the emergency response must fulfill. Yeah. For success. Yeah. There are at least two things: the technical skill, yeah, and managerial skill. It's called the system. In well-developed country, the technical skill and managerial skill may develop together, but it's not the case in my country. The technical skill develop first, and managerial is later. And to tell you about this, I will back to the history. Yeah. This is when tsunami struck my country in 2004. There is no established system dealing with disaster response in my country. Yeah. And there was no established emergency medical team, except one emergency medical team, Jakarta Emergency Ambulance Service, managed by Prof. So the other team is instantly create team. The team create just the day after the event. So you can imagine that I was the team. Yeah. And fortunately, our team, Yogyakarta Emergency Medical Team for Aceh, consists of ATLS alumni. So we can manage the team better. Even in my country, didn't have any system yet. Yeah. This is the team, looks like 26 members of the team, but no system in dealing with disaster in that time. Yeah. And this is missing in action, not means they are really missing, but they only missing for selfie. So they are not included in the big picture. Yeah. What the message after that? Yeah. What the message? I want to tell you about the situation. Yeah. In that time, we don't have any national system. Yeah. So, National Board for Disaster Response created 3 years after that event. It means after the 3 big disasters, tsunami in Aceh, tsunami in Nias 2005, and big earthquake in my city 2006. Yeah. So even in that time, my country didn't have formal definition for disaster. What is disaster? So in that time, I put the definition from Utstein Working Group, from World Association of Disaster and Emergency Medicine. And fortunately, when my country create definition, it's almost similar with that definition from Utstein style. So back to the idea when that in disaster response, like an emergency response, we must support it by 2 things: technical skill and managerial skill. Yeah. ATLS give technical skill is good enough, but not managerial skill. I already observe or read the module of disaster preparedness in ATLS module, but it's only as appendix, not in the main course. Yeah. And the scenario in the ATLS module is for major incident event, not for natural disaster or other conflict or other disaster like volcano eruption. So in my opinion, HES should move the content of disaster preparedness module to main course, not just as an appendix.
Yes, because in the module, it's assumed that all of participants already know about incident command system. Yeah, I read in the module, but in fact, it's not the case in my country. Almost all of us didn't know yet what is the incident command system. Yeah. I take a course of incident command system just in 2010. Yeah. The course is provided by California Homeland Security. I think so. It's like that. Yeah. So as conclusion of my speech, short speech there is, yeah. When ATLS alumni would like to take a part in disaster response, they must edit their skill with knowledge of disaster management. Yeah. Okay. Thank you very much.
We do have time for a couple of questions. The schedule has altered a little bit again, so we will be interrupting the session for the inauguration at 9 o'clock. But in the meantime, we'll have some questions for the speakers thus far. Narain, there you are. Come on up. Come on up. Any questions from the audience for our first speakers and the presentations this morning? I have a question for Professor Narain, in case you're just waiting to come up with yours. I enjoyed both of your talks very much. Narain, I was just wondering, the helicopter emergency retrieval system that you've got established now very much relies on the military. But as all things that are good usually grow, will your military continue to be a part of that, or will this also become something that is part of the civilian system in terms of helicopters and retrieval?
Actually, nowadays, even yesterday, we have the patients transported by helicopter. We still use the military helicopter. And in the future, we try our best to move the task of flying, the task of helicopter management out of the military to the civilian part. The local governor have a plan to buy a helicopter by himself for helping like prepare for disaster and also prepare for patient transportation routinely. We have planned, especially in Chiangmai. The provincial governor in Chiangmai, they also have a plan that they're going to purchase one helicopter for medical evacuation and medical emergency medicine at that time. But now we still use helicopter of military and police academy. Is that answer your question?
Yeah, no, it does. Wondering as well about training. So clearly you've done a lot of training to be in the position to help, because you're civilian, but with military connections as well.
Yes.
Is there ongoing training as well for that, or is it something that's just initial?
We still have the major course that we have trained people. The course has been designed by the Air Force together with the Air Force Hospital, and we have the course for basic and advanced. For basic, we took about 5 days. For advanced, it took more than that. So annually, they have this kind of training for people. So we send people to Bangkok to get trained and launch all over the country for capability of people.
Thank you. If you've got questions in the audience, please just stand up or raise your hand. Yes, we've got a microphone, I think, down at the front here. Hold on a second. There you go. Yes, please go ahead. And Asti afterwards, yes?
Thanks very much to all three speakers. I've got a question for our first speaker, and it's relating to the program that you were talking about in terms of the ATLS education here in Sri Lanka. So with that program, I understand that the trainings post the candidates finishing their medical school examinations, etc. And I guess my question there was, at what level post-medical school education is that training undertaken? And where do the resources sort of come from to help to promote that training, just in terms of getting an idea?
I think our initial speaker, Dr. Siva, had to go, so I'm not sure he can answer the question, but we might have, I think we do have someone else that will be able to answer. Thank you.
Unfortunately, he's not here. The system works it now. We have 5 years of medical school, and once we pass out, then you apply for the internship program, which consists of 1 year of training. It consists of mainly 4 specialties like pediatrics, surgery, general obs-and-gynae, and medical general medicine. So once that is done, they have another 1 year of training program. They work out of this field, and they undergo another rotation of 2 months in the specialties which they have not covered, like A&E, orthopedics, psychiatry, few others they cover, and they are eligible to get their permanent registration in the medical council. When that is over, in 1 year after completing of the internship, they are eligible to sit any postgraduate training program. So it consists of an entry exam where they have the 2 screening levels, and then they get into the field. So the amount of time of the training varies, whether it's general surgery or orthopedics, neurosurgery, but the surgery specialties go through a common entry exam. Then they select these out like we were. So at the moment we have branched out in neurosurgery, orthopedics, ENT, and ophthalmologies from the beginning. The rest they have a common training program, and after the exit they have their the specialized decision they make, like whether it's surgery or anything like that. Have I answered your question? Okay.
Thank you very much. We've got one more question over here.
My question is for Dr. Naren. I really appreciate for your work that the military sector can support the health system. What I want to ask you is how the community, the people in Thailand, activate the system. I think, do you have any special line, and how and who will be the responsible to decide, okay, the helicopter can respond the call or not, and which cases that the HMS can respond the call? I mean, is it for emergency cases or is it for only transferable? Thank you, Dr. Naren.
Did you get that question, Narain?
Okay, sorry, I cannot hear it quite well because it's quite echo in this room. But anyway, my understanding is the question is who is the one who make decision to activate this process. Number one, when we have a hospital in the local area who have the patient who has indication, we write the indication, 10, 15 indication for using the helicopter. And after they got that indication, they have to call to the doctor. We have the name list of the doctor every day who going to be the gatekeeper, make decision that the criteria is enough or not. And it's worthwhile or not to fly from that site to our hospital or to the big hospital in other places. The gatekeeper going to be the one who make decision. Okay, activate. After they activate, the Center of Emergency Medicine calling center, they're going to call to the military and find out which helicopter it's okay. Normally, we call the police academy first. If they have it, they activate the pilot, and we activate our team, and we go to see each other and fly. The helicopter should be in the same province as the team. Helicopter and the team should be in the same province. Otherwise, if you fly to pick up some people in the province and you fly to the other province, the team cannot go back because they have to go back by car. So the team and the helicopter should be in the same area. Activate both teams and fly. Now we are trying to make the activation time after call and take off, charter and charter. We still take time, 40 minutes something. But it's referral, it's referral. It's a secondary mission. So the patient get taken care by the hospital in the area, in the rural area, and wait for the helicopter to fly. So if we have our own ambulance, after activate, 3 minutes we fly, but we do not have that one yet. We still have gap, understand?
I guess the second part of the question was that were these evacuations in the various events you showed us, were they actual emergencies or was it just for the transport of patients from a flooded area to a normal area? Were there any emergencies also? No, the events which you had shown, were they actual emergencies, medical emergencies, or just for transport? I guess that was the second question. Yeah.
Both. Normally, routinely, they fly for help. Now we're trying to start the primary mission and fly to the incident area to pick up the patient back to the hospital. For the disaster, we have to establish the incident command system first. The incident command system is going to be the one who have every resources and activate the team to fly. Evacuate in the disaster, normal life, they just go and rescue and fly back to the hospital.
I just have one short question for Professor Hendro regarding disaster training in Indonesia. So you've got access to MIMS and the ATLS disaster part of it. Are there any other courses that you think you need, or is the training that you've got access to now in Indonesia, is that enough? Or do you need more?
I think we should more material for ATLS student and disaster management. Yeah, okay. I think so.
Thank you.
It's okay.
Thank you. As I mentioned before, we are interrupting the session for the inauguration session, so I'd like to thank all of our speakers from this first session this morning. I might also ask all of the ATLS programs who are represented here from around Region 16, if I could get the national chair or whoever's substituting for the national chair for all the ATLS programs up to the front, just so that we can introduce you to the dignitaries for the inauguration session, please. So just come up to the front row.
Break. I hope you all are refreshed and ready to continue. We will now resume the ATLS session, picking up from where we paused before the inauguration ceremony. It's my pleasure to invite our chair, Professor Scott de Amos, to guide us through the next part of this session. Please join me in warmly welcoming Professor Scott. Over to you, sir.
Hi, so we'll begin the session. My co-chair, Dr. Scott, is already here. I think the speakers are also here, so without wasting time, it's a pleasure to invite the next speaker, Dr. Osari Akaraborworn. Dr. Osari is, after doing her MD, she did her MS in trauma sciences and then PhD in clinical epidemiology. And right now she is the clinical instructor of surgery and also associate professor at the Prince of Songkhla University in Thailand. Dr. Osari will be speaking on the extracorporeal membrane oxygenation, that's ECMO in trauma, indications, outcomes, and special consideration. Dr. Osari, over to you.
Okay. Side. Click. Okay, while I'm waiting for my slides, have anyone here used ECMO before? Please raise your hands. Okay, a lot. I saw a lot. Okay. It's okay? So right now you can enjoy your tea while I'm waiting for my slides. Is that okay? Should I click any click or just wait? Just wait. Okay. Still plenty of time, right? Not plenty? Not a lot.
No, we got lots of time.
Okay. Do you want my computer here? I can have my phone. What? I think it's all right. Oh, okay. Okay, here we go. ECMO in trauma. So ECMO is a machine that is used as a bridging therapy by supporting heart or lungs or both. There is two major configurations in ECMO. The first one is VV ECMO. In VV ECMO, the blood is drained from the venous side, and from the, here you will see that the blood is go to the pump, go to oxygenation, and go back to the venous side. In the configuration, there is nothing to do with the heart. So VV ECMO is used for the patient that has respiratory problem with good heart function. And the next one is the VA ECMO. In the configuration of the VA ECMO, the blood is drained to the venous side, going to the pump, to oxygenator, and going back to the arterial side. So this one, the circuit is run parallel to the native patient's lungs, so it's used to support the patient that have a problem with cardiac function. If we go into the indication for ECMO, it's very simple. So either support the heart or support the lungs. But to make us get the clearer picture, how can we use ECMO into trauma patients? I think we have to think about what we have been using ECMO in the past. This is the study, this is the data from ELSO registry. ELSO is like a trauma registry, but it's for extracorporeal registry. It's the largest registry in the world that they collected data for 30 years. In the past, in this data, only 300 patients. You will see that patients that underwent ECMO, the primary injury is the lungs and the spine, abdomen, and extremities. But why those patients really need ECMO? According to the study, they say that half of those patients at the registry back then need ECMO because of they had ARDS and a lot of lung complications. And you will see some that has complications with the heart. With the data, the first information that we get that most of the ECMO that my patient use is a VV ECMO to support the lungs. The proportion that use VA ECMO is less than 10% from the ELSO study. It's also from the systematic review that collected data that published. They had larger proportion, around 500 trauma patients. They found that trauma patients that had ECMO, around 70% use VV ECMO and 25% use VA ECMO. Let's dig deeper on which type of trauma patients that have very bad lung pathologies and really need ECMO for respiratory support. This data from just one single institute that include patients for 75 patients. I think that they found that they have half of the trauma patients that need VV ECMO in their institutes has lung contusions, and followed by aspirations and TALI. Actually, this also correlated with data from my institutes. In the past, I have 6 ECMO trauma patients, and 5 of those has lung injuries. Like the slides that I show, this is the first film of the patient. When he arrived, you will see that this patient has the right lung contusion and the pneumothorax. We know that in the lung contusion, by natural history, is improved like around 3 to 5 days. And some literature says around 15% of lung injuries develop ARDS. This patient had clotted pneumothorax in the 2nd day, had cardiac pneumonia in the 3rd day, and the 4th day he had ARDS, and I could put him on ECMO. We could decannulate this patient at day 13. I don't have information about like the predictors that we can use to predict which lung contusion patients that's going to need ECMO, but there is a lot of predictors that was used to predict ARDS after lung contusions. You can use just a CT scan, or you can use focused ultrasound to see if the patient has a lot of B line in the lungs that's going to bad, or you can use a thoracic trauma score. The second reason to get the ECMO for trauma patient is aspiration. I think this one is quite straightforward, nothing much to talk. But I think the third one is quite interesting about the TALI. Have you experienced TALI patient before? Okay, few, right? Have you? Yeah. In my career, which is not long, I had 3 or 4 patients that I suspect that this patient has TALI. The interesting thing is, besides the bad oxygenation, those patients of mine, they produce a lot of positive sputum from the ET tube. And actually, it's related, it's aligned with this data that more than half of patients that has TALI, that had ET tube, they also have positive sputum from the ET tube. This is a case that I suspect that the patient has TALI. This one got blast injury because Thailand, my hospital stay in the south of Thailand. We had a lot of conflicts about the blast injury. So from the right side is the first chest seam that when he arrived after my hospital. He got liver packing from outside hospital, very bad injury at the right lungs and also right upper extremities. I put him on mechanical ventilator, used mechanical support, ventilator support for 3 days until the chest film looked better, which is the next one. And then I took him to the OR for the remove the packing. If you see that the initial PaO2 when he arrived at the OR around 300, which is quite high, and suddenly while I do the operation, the patient developed desaturation and produced a pink positive sputum from the tube. So the anesthesiologist team tried to manage the oxygenation by mechanical ventilators and their machines, but it failed. So I activated CV team to put the patient on the ECMO. And this is the next film. Right after the operation, you will see the opacity of the entire lung. And the opacity is stands still for like 2 or 3 days until improve. And then we can decrease the flow of the ECMO. So from now, we know that ECMO can use for respiratory support, right? For the first couple scenarios that we know, for the respiratory support with the patient that has very bad gas exchange. But before we decide this patient that, oh, this patient has inadequate gas exchange by a mechanical ventilator, you have to make sure that you do the optimal ventilator. What does it mean, optimal ventilator? This is the criteria for the ATLS study. ATLS study is the largest RCT that looked on the survival benefit of the ECMO. The ATLS says that you have to optimize ventilator by adjusting your FiO2, your tidal volume, your PEEP, and the respiratory rates. You can adjust those parameters according to your patients, but the key that you need to keep the plateau pressure below 32. Otherwise, your mechanical ventilator going to create worse lung to the patient. If you cannot manage the mechanical ventilator by getting good results, what it means when talking about good results, the patient oxygenation should be optimized by looking at the PF ratio. The ventilation should be adequate by look at CO2 retention. Which CO2 retention that we can accept at the intensive risk, we can accept as high as CO2, PaCO2 in the patient, but as long as the pH stay normal. So the next one, besides the gas exchange, another thing that ECMO can use to support the respiratory is for the airway. When we had airway injury, what do? We pass the tube to pass the injury site, right? Then we can do the surgery, repair the trachea. But what if the injury site is close to the carina and you cannot put the tube past the injury site to make adequate airway? That is the role for ECMO as well. I also have a patient, this happened like this year. This patient got transferred from outside hospital. The primary surgeon suspected that he might have tracheoesophagus fistula. So he was transferred to me with very bad oxygenation. This is the CT scan from the first hospital before the transfer. I do the bronchoscopy, and you will see that is the carina. And the dose hole is the hole that connects to the esophagus, and the shiny thing is the tube. So I put the patients on the VV ECMO before the operation starts. And from the operation, you will see that the huge hole at the trachea. You can see the endotracheal tube right away over there. If this scenario happened probably 20 years ago, right, before the ECMO era, this patient probably get cardiopulmonary bypass machine, right? But the thing is, the bad thing of, not the bad thing, the downside of bypass machine as you need heparin. There's never ever heparin free in bypass machine. And then bypass machines was created for the open heart surgery. So it will be placed for like intraoperatively. Luckily that this injury happened in the ECMO era. So I put the patient on ECMO. Actually it's like a VVV ECMO, 3 cannulas in place because this patient has a lot of blood flow. So right after the operation for a couple of days, I have to face with total lung atelectasis, which I have to do bronchosuction probably 4 or 5 times. If without extracorporeal support with this bad lung and do the bronchosuction, I think I would lose him at the ICU anyway after operation success. So right now, the indication for ECMO, we know for the respiratory support, for the gas exchange, and for the airway. The next one is for the cardiac support. I would like to divide it into subcategories, just simple VA ECMO or ECPR. If the bad heart, we call that VA ECMO. With patient arrest, we put the VA ECMO anyway, but we call that ECPR. Why should we divide? Actually, the VA ECMO accounted for 25% of the total ECMO rate. It's very hard to find literature that mention why did they put the VA ECMO on the patient. This is the largest one that I can get from the Canadian Trauma Center. All of those 7 patients, almost 7 patients that they had lung injuries. So those patients got VA ECMO, and they had really good survival rate from those data. The thing is about the ECPR with also the VA ECMO, I think we can think slightly differently. ECPR in the literature occur 4%. In my institute, we put ECPR in trauma in 2 cases, all of them die. But actually, the mindset to think which patient that you need ECMO, ECPR for trauma patient should be as same as any ECPR. The guideline of ECPR, the thing is we need patients to have good neuro outcomes. So that's why in my institute, all of ECPR patients that we're going to activate, they need to be witness arrest and have bystander CPR right after the cardiac arrest. The cardiac arrest time should not be longer than 45 minutes. And patient should not be in the advanced state or irreversible injury and not too old. Another thing is just contraindication for putting the ECMO. We know if the patient has aortic regurgitation, aortic stenosis, or aortic dissection, is the contraindication. Without the contraindication, if patient witness arrest with reversible cause, I think ECPR should be considered. The last 2 cases that I lost the patient, we almost activated ECPR, but the system is not work well. So we took this patient to the conference to say, why didn't we activate that ECPR in those patients? The first one, the one that suspect air emboli, another one is the one that lost the airway from the trauma. Right now, this is the general ECMO indications. Support the lungs, bad gas exchange, bad airway, support the heart when arrest, and bad cardiac function. But actually, in trauma, we have a special indication. There is an extended damage control. This concept was proposed by a Canadian group a couple of years ago. What did they do? They used an ECMO as an adjunct of hepatic vascular isolation. You remember this procedure, right? The one that every time that we did, all the patients die. Right? In hepatic vascular isolation, this group put the aortic balloon first in the arterial side and put the VA ECMO in the venous side. The thing is, when we say VV ECMO, not VA. When we're talking about VV ECMO, actually it can be placed in both femoral vein or one femoral vein and one jugular. But in hepatic isolation adjunct procedure, the drainage catheter have to be on the femoral vein, and the return cannula need to be in jugular vein, because the concept that they want the patient to have adequate venous return while doing the operation, and make the field at the liver dry and clean and easy to repair. And they also published good results. They had 8 patients. Actually, 6 of them can decannulate the ECMO. They lost 1 patient because of hepatic failure, and 5 out of 8 patients could walk home. Another adjunct to damage control is not from the Canadian group, but in my experience, is about the post-traumatic pneumonectomy. We know this is also the procedure that every time that we did, we are aware that we're going to lose the patient with the complication, such as the RV failure and then pulmonary edema. We can use ECMO to help to solve the complications. It can be both VV and VA. It depends on which complication that you are dealing with. If the patient has RV failure, the patient will be put on VA ECMO. If the patient has ARDS, the patient will be placed on VV ECMO. I also have the patient like this. Anyway, this patient got left main bronchus injury, and then when we try to prepare, the first attempt is one not success. He has unrepairable. So the CV team took the patient for pneumonectomy and prepared for the VV ECMO. But the patient had the cardiac arrest. In the cardiac arrest, we have to change the plan to put the VA ECMO and change to be like VAV ECMO. And at the end, the patient got pneumonectomy with VV ECMO and could go back home. So indications for now, I have 3 indications now for the lung support, chest support, and lung support, cardiac support, and then extended damage control. And what do the guidelines say? Surprisingly, I found 2 guidelines that say about ECMO in trauma. The first one is from the PDAST, is more like a consensus, and another one just published this year is from the Chinese society. I love the PDAST indication. They say there's nothing special. Just only one contraindication to put ECMO in trauma is irreversible injury, because we know that ECMO is a bridging therapy. They have to bridge to recovery, to bridge for operation, irreversible. It's not no for ECMO. In the Chinese, it's quite simple. They put 4 recommendations. The first 3 is for ARDS in polytrauma, in TBI, and also in inhalation injury. The first one is VA ECMO in heart failure. How about the outcomes? This is from the VV ECMO only. This is a propensity score match, and that they compare trauma patients that meet ECMO criteria. That means those patients that really had bad lungs, and then they compare the one that has bad lung and got ECMO, and had bad lung and just got only mechanical ventilators. And they found that the one that had bad lung that meet ECMO criteria, that had ECMO, had higher survival rate. So the first conclusion is in trauma patients that respiratory failure and need ECMO, put patient on ECMO, improve survival. The systematic review that report the overall survival in VA and VV ECMO. In the VV, we got better survival rate about 72%, and then VA is just only 40%. And a little bit about the short special consideration. In CBI, long time ago, we consider that it's a contraindication for ECMO, but actually the current study is not anymore. That is the study that collected data from patients that had VV ECMO with TBI and without TBI. They show there's no differences in terms of hospital discharge, and correlated with other systematic review that show that survival rate in TBI and non-TBI for VV ECMO is the same. What did the guidelines say? The guidelines, the AST says TBI has no longer contraindication for ECMO. And also in Chinese says in TBI with ARDS should get an ECMO. How about the heparin? Both guidelines says they encourage to use a tiny amount of heparin in trauma patients, but actually the heparin can be withheld for how many days? Actually, this statement is from the AST consensus. They says 5 days is okay. Actually, the entire run is still okay as long as the membrane oxygenator doesn't have evidence of the clot formation. So in my conclusion, I think I am also an intensivist. So when I have trauma patients that have that's candidate for the ECMO, I think of them as same as other patients. So trauma patient is nothing special. You have to control the bleed and before putting on the ECMO, so make everything easier. Just only one thing that I will not put the patient on ECMO is like irreversible patients, like almost brain herniated patients, or the one that would get bad prognosis. Thank you very much. I make it on time.
Thank you, Dr. Sari, for this very lucid and well-researched presentation on ECMO in trauma patients. We have time for some questions, I think. At the end. Okay. So we'll have the question answers at the end. Please note down your questions if you have for Dr. Osari. And now I'll call upon the last speaker of this session. Once again, Professor Narayan Chotirosniramit from the Chiangmai University. And Dr. Narayan will be talking on resilience. Yeah. Thank you. Please.
Thank you. Thank you very much, Professor Abid, for your kind introduction. This is my second talk, and I hope it's worked because this morning we have a little bit problem of the technical problem, so my video cannot play. And hopefully it worked. Got it? I use my own computer this time, just use a connector. Okay, got it. So my talk will be the preparation of the disaster. Actually, I have nothing to disclose. I'm just going to talk about my preparation, doing the plan for response for the mass casualties and disaster in my provinces. And also we talk about a real event that happened in Chiangmai. It's not a big event, actually, it's just a small event, but it's big for us. But it's small event for people who get used to the earthquake. Actually, I'm a trauma surgeon. I work being trauma surgeon at least 30 years now. And nowadays, I step up to be a dean of Faculty of Medicine, Chiangmai University. So I do a lot of administrative and also still take trauma call for 2 days per month. Even I'm a dean, still stick on the clinical teaching and clinical experience to take care of trauma cases. This is my whole team, 57 people who run our Faculty of Medicine this time. Actually, the event that happened in the 28th of March this year happened in Myanmar. That is the what they call the plate that moved, and earthquake happened near Chiang Mai. Chiang Mai is the red dot up north. Bangkok is down there in the red dot in the center of Thailand. But the problem is Bangkok, the ground is the soft mud. Chiang Mai is bedrock. So when they have a shaking, Bangkok have more effect from this earthquake. You can see in the news, television news, you have a lot of news of this building. But today, we're not talking about Bangkok. We're talking about Chiangmai. This is, I just want to let you know that the earthquake that happened in 28th of March, it's a very big one for Thai people. Because we have, in Bangkok, they have no experience about this. But in Chiang Mai, we do have the experience. It has been declared in the Act of National Act that this is a disaster that happened. Number 8 is an earthquake. So we live in the prone area. You can see the ring of fire. The Thailand is in the left corner. I can show you this one. This is the risk of earthquake in Thailand. The orange and red line is passed to the Chiangmai. So we live in that area. And by instance all over the world, the earthquake that is minor, I mean about 4 or 5 Richter, it's happened 10,000 times all over the world. Also in Chiang Mai, we feel it sometimes. Average, once a year, we will feel some minor earthquake in Chiang Mai. But it's not that big. But anyway, we think about we have to prepare. Because the step of the disaster management, the thing is we have to prevent the mitigate, prevent the destroy. We have to prepare for response, and then we have to think about recovery. The plan that had happened in Chiang Mai, we divided into 3 levels. The level of the community, I mean the family level, the provincial level, the hospital level, the provincial level, and regional plan. For the community level, many years we try to prepare the family knowledge about how you can do during the earthquake in the northern part of Thailand. We also launched the manual for management for the people in the family units, especially in the rural area, to know how to get down and cover under the table. And also encourage them to prepare the kits, I mean the survival kits during the earthquake, such as the flashlight, the food, rope, battery, and something inside the tank, inside the bag. We already teach them how to do it. Also in my house, I have my own bag in the storage room, during the stair of the first floor. If in an earthquake, I can grab this bag and go out. And also we teach the people who has the health volunteer in the village to know the response of the earthquake, and also teach the students to know. But our system of education is not as good as in Japan, because in Japan they do it all over the country, and they have the drill for the students. But we try our best to do it for our students in the northern part of Thailand. For the hospital level, this is my hospital. I showed this picture this morning already. We have to think about the provided care of our in-hospital patient during the earthquake. Number 2, we have to think about the injury patient that should come directly from the scene. And think about the patient who got referred from the outside hospital who has low facilities and sent to us. And finally, we think about deploy the response team to go out to help the other places. So it's a big job. During the 28th of March, we just prepare our hospital. From the beginning, nearly 20 years ago, we revised our mass casualty plan. Now I'm the chair of that meeting, and tell every unit in my hospital to prepare their own plan if we have mass casualties. Why? Because every people have to write themselves in each unit what they can do during I activate the plan, because they know their facilities. And we have a big plan, like a big umbrella, and they just have a plan of their own unit and come to present, and we have the plan to get along together. After we have it, we have the SOP. After we got the mass casualties in a big book, about 150 pages. And we conclude that, and we have the drill since 20 years ago. And we have a commitment to do the drill every year in April, beginning of April. And always, when we have this drill, the hospital director have to come. Before the drill, we have to ask the director, do you have time to come? They say, we have time. So we set up the drill at the day that the hospital director available. Otherwise, if he will not come, we cannot manage the command system. So we drill every year, variety of situations, every single year. Even during the COVID-19 era, we also do the tabletop drill to make people understand what we're going to deploy, what is the incident command system, what is the communications that we have in our hospital. This is me. I'm the deputy director of the hospital, and the man who wear the purple shirt is our director, who have to sit there and command in the EOC of the hospital. And also we have incident command system that has been declared for every people who responds for this in the hospital. The outcome is we have the actuation criteria. We do the quick and lean plan actuations. We have the incident command system, and we also establish the communication system inside the hospital. For the regional and provincial plan, we live in the region 1 of Thailand, so we have to come together and write the plan for Chiangmai province. Many hospitals have to come sit down and just write the plan for the provincial level. And we have the list of instruments, availability, facilities of each hospital in the province, what we can do. And also we have the major plan together with the governor of the province that we have this kind of plan. We call it major disaster plan of the province. And also we have the incident command system to get along with the FEMA standard. And we also have the workshop for the ICS. We established the EOC for the provincial area. And also we have the way of communication through the Center of 1669. We call the Emergency Center Coordination Center that have to cooperate in every unit. We have the radio communication frequency that's separate into 3 channels. It's a command channel, operation channel, and logistic channel. And also we establish the frequency that we should go to meet each other during the earthquake if we have something losses. Mobile phone cannot work. You go turn on the radio communication, go to 1.154.975. It has been written to the major criteria and the manual. And also we have the common triage from the scene and train some special persons such as the search and rescue team, 120 people in Chiangmai. And also the hazardous material team who get used to how to do the decontamination, to establish a hot zone, warm zone, cold zone. And also we have Northern Sky Doctor that has been mentioned this morning. So we still work, the Northern Sky Doctor team who still work together. That is the video that I want to show you this morning, but it doesn't work. This is a helicopter that landed in my soccer field. And also we have the response team, we call the CMR team, composed of 11 members, physicians, nurses, paramedic, EMT, and also the first responder who has been activated go out. And we have the field hospital manual to write down when we want to establish the field hospital, what kind of instrumental list that we have to, what is the plan of the put in the tent or the temporary area to take care of the patients. And also we have the tabletop of the whole province to try to exercise what we're going to do if we have the building collapse. And so we have the full-scale earthquake response exercise involving the USAR team and CMR team cooperate together in the whole province. For the real situation, in 28 March of 2025, I stepped up to be a dean at the end of January. After that, 2 months, the event happened. This is the video that has been taken inside the conference room in the top floor of the hospital. Could you give me the sound, please? Hopefully it works. And just, okay, you got it? Sorry. I just get from the Facebook of my nurse. She's during the training of emergency nurse practitioner, and we got the earthquake at that time. And the second clip gonna be the video that I have the meeting between me and the administrative people, the head of department, so many people in the conference room, and we have the earthquake. And number one, when you are a leader, you have to think about it, make it quick and accurate decisions. This is subtitle. We speak in Thai, but we have subtitle in English. This is the room that we have the conference together with the head of department, 23 people. This is start to change during the meeting. I'm the head of the table at that point. They all get trained. automatically they go under the table. You can see our head of department, even they're 60 years old, they're just under the table. And they will not run. They will not and they have to go down by the stairs, not the lift. The thing is, after we come down by the stairs down to the floor, we found that the patient has been evacuated already. About 200 and 300 patients has been evacuated already. Patients who are walkable come down here together with the nurses. Very chaotic. Even we have a drill many times, it's chaotic because so many people run around. When they get into that point, they see the truck. So we just step up to the truck. And very short of the scene, machine with the machine several years. But when there is one there, machine is and use the
สำหรับผู้ที่เดินได้อย่างฉับต้องตื่นขอให้รอข้างนอกก่อนนะครับในพื้นที่ที่พวกเรากั้นไว้เนี่ยเป็นพื้นที่สำหรับคนไข้ ER ที่เราย้ายออกมาเดี๋ยวขอเวลาประเมินสักครู่ฝั่งพยาบาลนะครับที่ดูแลผู้ป่วยวิกฤตบนตึกผมคิดว่าตอนนี้ยังไม่ต้องเคลื่อนย้ายนะครับเพราะการเคลื่อนย้ายผู้ป่วยวิกฤตที่ใส่เครื่องช่วยหายใจบนตึกมีความเสี่ยงสูงเพราะเป็น
It's nothing, we just mentioned that you should not evacuate the ICU patients because we cannot use the lift. We have to use the stair coming down. The patient with so many monitoring ventilator, if you move them, they're going to die. Because the shaking is not that much. The building will not, I think the building will not collapse this time. Even it collapses, you all die. So we just wait for the critical patient. But patients who are walkable, they can bring it down. My hospital is 1,400 beds hospital, so about 900 people come down on the floor. So we have to manage. Some people have to manage it. It's not to be the other one. It has to be Dean because Dean was there. So I have to step up. So we need to do the communication clearly and transparency. We use the radio. I have this kind of radio, about 30 radios in my hospital. I just send it out. And we have a box for the mass casualty box to manage everything, even the triage system, and separate patients. And we have to communicate to people outside the hospital that the hospital closed now. If you want to come, you just come for the real emergency. Outpatient unit, we close, you go back home. We will make an appointment for you through the line officials of the hospital. People who are waiting for medicine or pharmacy, go back home, come back tomorrow. The pharmacist is going to manage the drug for you tomorrow. Tomorrow is Saturday, today is Friday. Tomorrow we're going to open for people who just go home before they get the pharmacist, the
เรียน
medicine.
พ่อแม่พี่น้องชาวเชียงใหม่และจังหวัดใกล้เคียงที่มีญาติพี่น้องป่วยอยู่ในมหาลัย
For people in our TikTok, we have Facebook, we have IG. So we send it out immediately after about half an hour. We just take time about 1-2 minutes to announce that your counseling, your relative in the hospital has been taken care. Don't worry, don't come to the hospital. Otherwise, we cannot manage the counselors who come.
เรียนพ่อแม่พี่น้องชาวเชียง
And then the leader have to do the like moral anchor. Some people have to show up at that time. Otherwise, it's going to be very chaotic, busy, it cannot manageable. So there should be someone, director, dean, vice director, vice dean, anyone who know about the system of command system. Don't let people who don't know anything to lead. Otherwise, it's going to be more chaotic. So they have to know the drill that we have done many times. So they have to step up. And we have managed the resource because we have the plan. We activate the plan, so we activate people. The EOC, we think we have the EOC in the conference room, we cannot use it because of the earthquake, we cannot get into the building. So we use the EOC on the ground, on the field. So we have meeting by words and have some people who run and use walkie-talkie to talk. And also our nurses evacuate the patient down to the field. Many patients, 900 patients come down. And also we start to transfer the patient back to the wards after we make sure that there's nothing to happen, just bring the patient back. And we have coordination and collaboration, such as the army group, police, first responder, security come to help us. And also we have the engineer team who can walk inside the building to check what's going on in the building before we move the patient back in the building. So this volunteer is the engineer who knows the construction of the building. They just walk in the major building of the patient and looked in everywhere that is there anything that warn us about the instability of the building. They come back to me after 1 hour, said every building for the patient is okay. So I moved the patient back in. And that the day after that, our governor come to visit the hospital. We do have some damage. You can see some cracks on the wall, some bridge between the building has been cracked. Some of the dormitory, we cannot use it because completely destroyed. We cannot use it. We have to move our doctors out to the other places. Also the bridge between the building. When it checked opposite direction. The bridge has been destroyed, collapsed. So we cannot use it. We have to close it. We closed it for about 4 months. And now it's open again because we have to rebuild the bridge between the building. And also the skywalk, also unstable. We have to use the construction to make it stable and open it again after that. Also, we announce for the people that the hospital is safe for the treatment area. You can come to the hospital on Monday. We close it, it happened on Friday. Saturday, the people come back for the pharmacies, for the medicine. Monday, we come back and work again. And we have to do the continuous learning and adapting. We have the after-action review, about 5 days. We call every people come and just sit and talk about our plan. Is there anything to change? So we changed our plan from the version 1 to version 2. We changed the consideration about when to evacuate. Assembly point, patient evacuation areas, equipment and supplies, the return evacuation, go back to the building, command structure, EOC location, communication, receiving new patient. We have need to improve our guideline. And we changed the level of activation by not use the Richter, because Richter you have to wait. We use the Mercalli scale. They will know when to evacuate, such as you have something falls from the shelf, shaking, some collapse of the ceiling, they have to move out. If just checking, small checking, don't move, very risky. And so we revise our incident command system again, and so we have a role and responsibility for each people, and we divide it into level 1, level 2, and level 3 response if we have that kind of earthquake again. And we have the assembly area map for the people who work in the hospital, and also the area for the patients who come down, the red area, green area, yellow area. So this is the whole thing. My summary is, the thing is we need to preparations for the response. You have to make quick and accurate decision by the leader. You have to communicate clearly and transparency. You have to have a leader who serves as a moral anchor for people, and also manage the resource, contingency planning, and also coordinate and building collaboration. People outside can help you, and also continuous learning and after action review. Don't think about if it happened, just think about when it happened. So you should have your own plan, and the plan should have a drill, and revise the plan every year. Thank you very much.
Wow, thank you very much. That was phenomenal. I know there are going to be questions for you. I think we're going to have to do some of the questions during lunch. I apologize for that, but we want to keep things on schedule. So for both of our speakers,